So here's a case of a 47-year-old female who presented with shortness of breath and leg edema. She was found to be hypotensive with a blood pressure of 80/55 mm mercury. Here the ECG shows a regular rhythm with the distance between the R wave and the next R wave slightly less than 3 large squares, which means the patient has tachycardia. In this case, it is a sinus tachycardia of around 110 beats per minute. Another feature seen here is the low QRS voltage, which is defined as QRS amplitude of less than 5 mm in all limb leads or less than 10 mm in all precordial leads. Here, you can see the QRS amplitude in all of the precordial leads is less than 10 mm or 2 large squares, which means the patient has a low QRS voltage. The third feature here is the alternating height or amplitude of the QRS complexes. And we can see here a short QRS complex followed by a taller QRS complex, followed again by a shorter one, and so on. This cyclical variation of the QRS height is called QRS electrical alternance. And the combination of these three findings on the ECG is highly suggestive of cardiac tamponade. The pericardium is a fibroelastic sac that encases the heart. Normally, it contains small amounts of pericardial fluid which act as a lubricant as the heart beats inside the pericardium. Cardiac tamponade is when fluid accumulates within the pericardial sac to the point that it starts compressing the heart, resulting in impaired cardiac filling and hemodynamic compromise. The pericardium has some degree of elasticity. When pericardial fluid accumulates, the pericardium is able to stretch and accommodate the increased fluid. But when the pericardium reaches its elastic limit, the fluid starts to compress the heart, resulting in tamponade. The point at which this occurs is largely determined by the rate of fluid accumulation. So, when pericardial fluid accumulates gradually, the pericardium is able to stretch and accommodate the increased fluid until it can no longer stretch and tamponade ensues. So typically, when the accumulation is more gradual or chronic, larger quantities of fluid are required to cause tamponade. Conversely, in cases of rapid or acute accumulation, such as acute bleeding into the pericardium due to trauma, the pericardium is unable to stretch adequately, and relatively small amounts of fluid can result in tamponade. Symptoms of cardiac tamponade are often nonspecific. Shortness of breath or dyspnea is the most common presenting symptom, but patients may also present with chest pain or cough. While dyspnea is the most common presenting symptom, the evaluation of shortness of breath in the emergency setting is often directed at ruling out more common causes of shortness of breath, such as heart failure and pneumonia, and therefore, the diagnosis of cardiac tamponade can easily be missed. Signs of cardiac tamponade include Beck's triad, which is jugular venous distension, hypotension, and muffled heart sounds. The heart sounds are muffled because the heart is surrounded by fluid which interferes with the transmission of heart sounds during auscultation. The accumulation of fluid around the heart results in impairment of diastolic filling, ultimately leading to jugular venous distension and hypotension. The body responds to the drop in cardiac output by increasing the heart rate, and patients may have sinus tachycardia. And finally, there may also be pulsus paradoxus, which is a drop in systolic blood pressure of 10 mm mercury or more during inspiration. The ECG may provide the first clues to the diagnosis of cardiac tamponade. Sinus tachycardia is the most common ECG finding, and low QRS voltage may also be seen as shown in the first slide. And QRS electrical alternance is the beat-to-beat variation in QRS height, and this is caused by the swinging of the heart inside the fluid-filled pericardial sac, where the electrical signals, as detected by the ECG electrodes, cyclically travel over greater and then shorter distances through the fluid, resulting in short followed by taller QRS complexes in a repeating pattern. And this finding is relatively specific for tamponade, but is not sensitive. And when the electrical alternance involves the P, QRS, and T waves, it is called total electrical alternance or electrical alternance totalis, which is thought to be pathognomonic for tamponade but is uncommon. Finally, if the tamponade is the result of pericarditis, we may find ECG findings of pericarditis, such as diffuse ST elevation and PR depression. This is an X-ray of the same patient from the first slide. and the accumulation of large amounts of fluid around the heart causes the cardiac outline to enlarge, mimicking an old-fashioned water bottle. Now this is known as the water bottle sign. Nevertheless, a normal chest x-ray cannot exclude tamponade because in acute cases when there is rapid buildup of fluids, even small amounts of fluid can cause a tamponade and the heart appears normal on x-ray. So, patients with tamponade may or may not have an enlarged cardiac outline depending on the amount of fluid present in the pericardial sac. The diagnostic modality of choice is echocardiography, which reveals accumulation of fluid in the pericardial sac with tamponade physiology. And this is the echocardiography report of this patient, which revealed a large pericardial effusion with right ventricular diastolic collapse consistent with tamponade. Treatment involves volume expansion with a bolus of normal saline, but this is just a temporary measure to improve the hemodynamic status of the patient, while a more definitive measure is being undertaken. The definitive treatment is aspiration of the pericardial fluid, and this is usually done via a needle that is inserted through the chest wall into the pericardium in order to aspirate the fluid and relieve the compression on the heart. This process is called pericardiocentesis and is usually done under ultrasound guidance. To summarize, cardiac tamponade occurs when fluid accumulates within the pericardial space, compressing the heart and impairing diastolic filling. When the accumulation of fluid is rapid, even relatively small amounts of fluid can cause tamponade. When the accumulation is slow, larger amounts are usually needed for tamponade to develop. Clinical features are nonspecific, and dyspnea is the most common presenting feature. ECG may show sinus tachycardia, which is the most common finding on ECG, low voltage, and electrical alternance. The chest X-ray may or may not show an enlarged cardiac outline, depending on the amount of fluid present. Echocardiography is the diagnostic modality of choice and confirms the diagnosis. Treatment includes IV normal saline, which is just a bridge to definitive treatment, pericardiocentesis being the definitive treatment, and in some cases, patients may require surgery.